Okay, so in this lecture series, I'll be talking about fracture of the neck of the femur. So, fracture of the neck of the femur was a deadliest complications until and unless new intervention of orthopedics did not come into practice. So, this is the head of the femur. This is the fracture. This is the neck of the femur, and then you have the greater trochanter and the lesser trochanter, and then this is the shaft of the femur. So anyway, the fracture over here is actually a problematic. Now why is it problematic? Number one, it's an intracapsular fracture. So what happens if it's an intracapsular fracture? If it's inside the capsule, there's basically the synovial fluid. Okay, this synovial fluid actually it destroys the fracture hematoma being formed, which is being formed. That is why there's no proper healing. So if the fracture hematoma is destroyed, so there's no recruitment. So this is the initial stage of fracture healing. From your basics, this is the initial stage of fracture healing. So if in case there is no hematoma, there won't be proper healing. No proper healing. Okay, no proper healing. So that is why we are concerned about fracture of the neck of the femur. Number two is actually fracture of the neck of the femur. Fracture of the neck of the femur is actually there is high chances of going under non-union. High chance for non-union. Now why high chance for non-union? Because of the lack of blood supply. Okay, the blood supply is very minimal at this particular area. What you need to remember is there is, so let me take a red pen. So there is this artery which is known as a profunda femoris artery. Okay, profunda femoris artery, it has two branches. One is the medial circumflex artery, other one is the lateral circumflex artery over here. Okay, and there are these retinacular vessels, okay, retinacular arteries running all around over here, and here is the artery of the ligamentum teres. Okay, so the thing that you need to remember is, even though there are a lot of arterial supply that is being shown over here, the predominant artery is the medial circumflex artery over here, and which I have shown. This is actually the predominant artery. Okay, the lateral circumflex artery, it has three branches. One is ascending, other one is transverse, other one is descending. Ascending, transverse, and descending. But the most predominant is the medial circumflex artery. Please understand this. Predominant medial circumflex artery. Okay, MCA. Predominant is the medial circumflex artery. You have the lateral circumflex artery. Okay, lateral circumflex artery, it has three branches: ascending, transverse, and descending. Okay, now the next thing that you need to remember is, now what is actually non-union? Okay, no high chances of non-union. Other one is, it's an intracapsular fracture. So synovial fluid, if there is formed, then that will lead to no hematoma, and there is no no formation. And other one is this neck of the femur, it lacks the cambium layer. So over here, there is, particularly over here at this particular area which I'm thickening, there's no cambium layer at this particular area. Cambium layer is lacking. So what does that mean? That means at this particular area there is lack of osteoblastic cells. So osteoblastic cells are lacking at this particular area, because of which these osteoblasts can't work up. So we are much more concerned about this for fracture of the neck of the femur. Now what would be the presentation? How would the patient present with fracture of the neck of the femur? So when there is a fracture at this particular area, this fracture may be a complete fracture, maybe an incomplete fracture. So we needed a classification system. So one is an anatomical classification, one is a broad classification. First of all, I'll talk about the broad classification. Okay, broad classification classifies it into intracapsular and extracapsular. And next one is actually anatomical classification. So in the anatomical classification, what do we have? In the anatomical classification, we have three types. Okay, three categories. So what you can see here is, this is the head of the femur. This is the neck of the femur. Greater. Now this is actually subcapital, which I have marked. Okay, subcapital number one. Number two is actually transcervical. Number three is basicervical. Okay, one is subcapital. Second is transcervical. and basic cervical. Okay, so these are the basic three things that you need to remember. And next is actually your actually Powell's classification. So Powell's classification, what does Powell's classification say? Powell's classification, it says that fracture of the neck of the femur, fracture of neck of femur, it's divided on the basis of fracture lines. Suppose if this is the neck of the femur and here you have, so there is a fracture line over here, right? So this fracture line, there's a horizontal line which is drawn from the fracture line. Okay, and there is an angle basically which is being made. Now this angle, if it's less than 30 degree, 30 to 50 degree, or more than 70 degrees, so this is the classification. So this is Powell's type 1, type 2, type 3. Remember, as the increase in the Powell's angle, bad the prognosis. And here in the anatomical classification, the best prognosis is the basis cervical, because at this particular area the capsulate ends, right, and this becomes extracapsular. Basically basis cervical fracture is more over towards IT fracture, but not completely IT fracture. We can't just say this as an IT fracture. It falls under neck of the femur, but it's slightly extracapsular, so better healing at this particular area. IT fracture is over here, that is the transfers between the two trochanter, greater trochanter and the lesser trochanter. Now I hope this is clear. Now the last classification, the most important one, is the Gardner's classification. Okay, so in the Gardner's classification, what is the most important thing is that you have to remember is there is type 1, type 2, type 3, type 4. Okay, type 1 means the fracture is there is a fracture, but this fracture is not completely displaced. Okay, there is a partial fracture, there is no displacement. Okay, partial fracture, no displacement. Type 2 is there is a complete fracture and there is partial displacement. Type 3 is complete fracture. Sorry, this is a partial fracture, no displacement. Okay, partial, you have to say it an incomplete fracture with no displacement, right? Here you have partial displacement, there is complete fracture. Here you have complete fracture. Sorry, this one is slightly sorry. Okay, here there is no displacement, but here there is a complete fracture and there is partial displacement. Here there is a complete fracture and there is a complete displacement. Okay, in this way. And this Gardner's classification is also based on the trabecular pattern. So you need to remember that this trabecular pattern of the acetabulum, head of the femur and neck of the femur, this is actually preserved in type 1 and type 2. Okay, altered in type 3, and in type 4 it becomes parallel. The trabecular pattern becomes parallel. Okay, I will show you in the next lecture all the diagrams so that it becomes easy for you. Okay, now next thing that you need to remember is, now classification is also done. Now how would the patient present with? The patient will be an old age female, roughly around 40 to 50 years of age, maybe 50 to 60 also. Why this age group? Because it's common in this age group. Okay, it's common in this age group. Now why is it common in this age group? Because the bone becomes osteoporotic. And it leads to pathological fracture. Now what is pathological fracture? Pathological fracture does not mean there is a fracture and then there is a pathology. It means there is a pathology and that pathology is followed by fracture. First of all, there is osteoporosis, and after an osteoporosis there is a fracture. That's why this is a pathological fracture. Okay, now it might happen because of certain trauma, because of certain trivial trauma. It might happen, like catching the toe in the carpet, similarly falling in the bathroom. Okay, now it might happen also in young adults in the case of trauma associated, like RTA, or maybe associated other fractures. Okay, but the most common is the old age female, pathological fracture, trivial trauma. So in this condition, I suspect two fractures. One is fracture neck of the femur, which is very, very common, or the second one is also the intertrochanteric fracture. Okay, this can also be seen. But remember, the differentiating factor between these two is the presentation. So the limb will go under external rotation, that's for sure. But this external rotation is more than 45 degrees in the case of intertrochanteric fracture. but it's less than 45 degrees in the case of fracture neck of femur. Now, why is it less than 45 degrees? Because capsule which is present, it limits the external rotation. But more than 45 degrees, there is no capsule. Intertrochanter fracture means it's an extra capsular fracture, isn't it? So there will be more than 45 degrees, and because of which the the lateral part of the foot, it touches the bed. So this is the presentation in the case of this one. Okay, now fracture neck of femur, one is for sure there is an external rotation. Okay, there is an external rotation. Now, so I hope we are clear till here. Okay, so it's quite a long topic to be explained, fracture neck of the femur. The second thing that you need to now remember is fracture neck of the femur, the treatment modalities of fracture neck of the femur, which is very, very, very important when it comes to your understanding fracture of the neck of the femur. Now, there's an algorithm. Algorithm for treatment of fracture neck of the femur. Now, the first says that look at the age of the patient. So, if the age of the patient is more than 65 years, just go for total hip replacement or go for a partial hip replacement. Don't think too much for more than 65 years. Very easy for us. Either you go for a total hip replacement or you go for a partial hip replacement. If you go for a total hip replacement, that means you are replacing the acetabulum as well as the head and neck of the femur. Okay, but if you talk about a partial hip displacement, what you need to remember is partial hip displacement, you are just actually replacing the head and neck. Okay, head and neck. And there are three important partial hip displacement. When you just go for a partial hip replacement, there is three. One is Austin Moore, other one is Thompson, other one is bipolar. Remember, B for bipolar, B is best. Okay, total hip replacement, you have to replace the whole hip. Okay, total hip replacement is done in previously unhealthy hip. That means the hip, it consists of certain pathology, like maybe that might be an osteoarthritis. So one algorithm is this. Okay, and age of the patient, if it's less than 65 years. Okay, very, very important. Listen to this very cautiously. Okay, because this is often asked in the examination. Less than 65 years, what you need to see is if it is less than 3 weeks, the fracture, that hematoma, if it's more than 3 weeks. Now, why I'm looking at this? Because 3 weeks is the time where you can just remodel the fracture. More than 3 weeks, you have to go for osteotomy, right? Now, less than 3 weeks, what you can do is you can go for close reduction internal fixation with cortical cancellous screw. Okay, just remember this much. Less than 3 weeks, you can go for close reduction internal fixation with cortical cancellous screw. But if in case there is an associated nerve injuries or arterial injuries, you have to open the fracture. No doubt, whatever be the time, there is an associated nerve injuries, associated arterial injuries. There is this, neurovascular status is not well maintained. Go for an open reduction. But if in case we can go for close reduction, go for close reduction. If it's more than 3 weeks, I told you, more than 3 weeks, it has already become a hard callus, right? From your basics of fracture healing. So what you do is, you just see whether the this head of the femur, is it viable or not? Number one, viability. Number two, non-viable, or it is dead. Okay. So if it is non-viable, you want to make it viable. How would you make a non-viable component a viable component? Non-viable, how is it made viable? So you have different procedures of vascularization, like Meerdings and Bakshi. Okay, Meerdings and Bakshi. Now what is Mears? Mears, M for Mears, M for muscle. So there is something which is known as a quadriceps muscle. quadriceps femoris. So what you do is quadratus femoris. Okay, quadratus femoris. So what you do is you just cut the quadratus femoris and fix it. You don't need to know more here. Just remember that there is Meerdings and Bakshi. Bakshi is associated with tensor fascia lata. Bakshi is associated with quadratus femoris. Now, if it's a dead, no doubt you have to go for joint replacement. You have to go for partial or total joint replacement, hip replacement therapy for sure. Okay. But if it's not viable, now if it's a viable, what we'll do? Like the head is viable, it's good. Okay. So you can go for osteotomy. You can go for either McMurray's osteotomy or you can go for a Powell's osteotomy. So if you go for a Powell's osteotomy, what are you doing? You are decreasing the Powell's angle. So I already told you that whenever there's an increase in the Powell's angle, what happens? The prognosis is bad. So what you'll do is you just decrease. Like if it's 30 to 50 degrees, you make it a 30 degree and then you go for a, you can either go for a hip spica or anything else so that there's a better reduction. So that is basically known as Powell's osteotomy. Other one is McMurray's. So what do you do in McMurray's? In McMurray's, what you do is, in McMurray's is also one of the clinical tests for actually your meniscus injury. Okay, so we are not talking about that right now. We are talking about McMurray's osteotomy. In McMurray's osteotomy, what you do is, this is the head of the femur, this is the neck, and then the neck has been fractured. So what you do is, from the acetabulum, just direct this, this shaft of the femur in such a way that all the weight falls onto the shaft of the femur. Okay, so this is basically the McMurray's osteotomy. So this completes our treatment of a vascular necrosis of the head of the femur because of the fracture. Okay, so if there will be avian, then you have to go for, of course, joint replacement. That's for sure. So I will just talk about this more in the next video and along with the diagrams. Thank you.